first. By that
Okay,
time,
sir.
sir will join. He has reached.
Okay, sir. Definitely, sir. Namaste all. I hope I am visible and audible.
Yes. Loud
Yes.
and clear.
Yes. Namaste and a warm welcome to all of you joining us today for this webinar. Once again, I would like to apologize to all the participants for the delay caused, but it was unavoidable. Even though we tried to reschedule it, there are some situations that are beyond our control. So with this, my apologies. I would further extend today's webinar. I will begin with it. It is with great pleasure and anticipation that I, Dr. Pallavi Chaugule, Associate Professor and HOD Department of Rog Nidan Vikruti Vigyan, Manjushri Institute, Gandhinagar, working as Joint Secretary of RVPGA, welcome you all to yet another fantastic 28th webinar on constipation clinical laboratory diagnosis. This webinar, conducted by Rog Nidan Vikruti Vigyan PG Association, is already approved by Maharashtra Council of Indian Medicine, Mumbai. Constipation is a very sensitive yet common issue affecting millions of people worldwide, regardless of age or background. It can be a very uncomfortable and frustrating experience owing to the fact that it's a very personal issue, and yet it's important to address it effectively. As we gather here to delve into the intricacies of digestive health, I am honored to welcome our distinguished speaker, Dr. Saurabh Patale, sir, renowned gastroenterologist, and our today's chairperson, none other than our visionary and ever enthusiastic president of Rognidan Vikruti Vigyan PG Association, Dr. Subhash Wage, sir. I welcome you all, sir. But before we dive in, let me call upon Dr. Rishita Dailekar, Madam, Professor and HOD, Department of Rog Nidan, Parul Institute of Ayurveda and Research, Vadodara, to brief us about the Rog Vigyan PG Association. Ma'am, over to you. Rishita, ma'am. Hello, am I audible? Hello, hello, am I audible? I'm not getting any response.
You are
Hello.
audible. You are audible.
Rishita ma'am, may I call upon, may I request you to give a brief introduction about our association to our audience?
Rishita madam, please unmute yourself. You are not audible. Please unmute yourself. Rishita madam, unmute yourself. Yes, now you. I think you have done it.
Uh, 1 minute. I'm audible now?
Yes, you are audible
Yes,
now.
ma'am, you're audible now.
I'm using the microphone, but it's not connecting. Okay. So sorry for delay. Thanks, Pallavi ma'am. Actually, it is a great privilege to introduce such a perfect organization in all aspects of the Ayurveda. It is a Rognidan Vikruti Vigyan PG Association, and this association is formed under the dynamic leadership of Dr. Subhash Wage sir in the 2016, and with the aim to give the legal status of pathologists and radiologists to our PG Rognidan students. It is the main motto of this association. The RVPG Association is duly signed under the Society Act of 1860 at Charity of Commissioner Office in Nagpur. The postgraduate students of the Rognidan Vikruti Vigyan, Chaya Vikruti Vigyan, and the faculties can become the member of this association. Our is the first only organization that is fighting for the legal rights for the Rognidan and Vikruti Vigyan PG students. Even the NCISM had already directed to the state government of Maharashtra to consider RVPGA as a stakeholder in the constitution of pathology regulatory body of the state. RVPGA is pursuing this matter with state and central government. Not only this, but RVPGA is constantly pursuing the implementation of the NCSM salary structure in all our communication and details are available, are uploaded in our website, that is www.rvpganagpur.com. Apart from these legal activities, RVPGA is continuously putting effort for the skill development and the academic growth of the Rog Nidan Vikriti Vigyan PGs. Here, highlighting some educational activities of the RVPGA till the date, such as the regular conduction of online webinars and offline webinars on the national and international platform. So far now, we conducted total 23 national webinars on the different diagnostic topics and a national conference on X-ray diagnosis at Nagpur. Hands-on training of the program for the PGs at our NABL accredited lab, pathology lab, that is held in the Mumbai, Nagpur and Pune. RVPGA is now going to plan the microbiological hands-on training program for Ayurveda PG students from the 9th March 2024 at Nagpur. Other than this, the publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostic and Research, that is IJDR. Interested can visit this journal site, that is the www.ijdrindia.com. Our journal is enlisted in total 8 databases, and till the date, the 2 issues have already published. Also, we are publishing book chapters through our edited book volume series, which is an international publication called RIPI and is duly registered in the Government of India with ISBN portal. Those who want to contribute book chapters can visit the RIPI website, that is again www.rvpgiip.com. RVPGA has published All India Rog Nidan PG thesis book consisting of all Rog Nidan PG titles from the 1985 till 2023 for the easy reference of our PGs and faculties. This year, now the Rog Nidan Vikriti Vigyan PG Association is going to start the 2 diploma courses, that is the DAPT, that is a Diploma in Advanced Pathology Training, and DAXDT, that is a Diploma in X-ray Diagnostic and Techniques. Both the courses are affiliated by the reputed RST Nagpur University. We request aspirants to take the benefits of it and go through the website. We are giving legal fights for the issues of Rog Nidan and Vikriti Vigyan PGs at appropriate forums. Now, last but not least, RVPG Association have its own YouTube channel and Facebook pages where you can see various past and live educational activities. Now, I request Pallavi ma'am to take forward today's webinar. Over to ma'am. Hello, Pallavi ma'am.
Thank you, ma'am. Thank you for the brief introduction of our association. Thank you so much, ma'am.
Yes, our speakers are had joined, and please carry forward the further proceedings.
Yes, sir. Patients suffering from vyadhis related to Mahasrutas form a majority of a physician's practice. In Samhitas, the function of Purisha is mentioned as Agni Vayu Avastamba, that is, Dharana of Agni and Vayu. Also, the Purishva Srotas mentions Srotodushti Lakshana like Kurchrena, Alpa Alpam, Sashulam, Grathita Mala Pravruti. Apart from these, various Lakshanas related to Purisha like Malasanga, Baddhavarcha or Varcha Vinigra, etc. are explained to differentiate Sam and Nirama Avastha in a patient. So it becomes completely essential to know about the constipation and its clinical utility in detail. Though constipation is included in our syllabus also, it is one of the most neglected parts. But today, we are honored to have Dr. Saurabh Patale, sir, renowned gastroenterologist, for joining today's webinar as our speaker. I would like to introduce our speaker. Sir did his MBBS from Grant Medical College and JG Group of Hospitals, Mumbai in 2009. Further, he pursued his DNB in internal medicine in 2014 from Medwin Institute of Medical Sciences, Hyderabad. His quest for knowledge led him to further acquire DNB in gastroenterology and hepatology in 2019 from Medanta the Medicity, Gurgaon. He did his 2-year fellowship in hepatology and further continued his fellowship in advanced endoscopy from Medanta the Medicity in 2020. Sir has done more than 20,000 endoscopic procedures, including complicated and rare procedures like endoscopic USG, endoscopic retrograde cholangiopancreatography, and spyglass cholangioscopy, oral endoscopic myotomy, endoscopic submucosal dissection, endoscopic mucosal dissection. Sir has a vast experience in liver transplantation workup and post-transplant management, and also has expertise in managing critical gastroenterological diseases like pancreatitis, liver failure, and inflammatory bowel diseases. Sir, Dr. Saurabh Patale, sir, brings a wealth of knowledge and experience to our virtual stage. His expertise in gastroenterology has transformed the lives of countless patients. He will share his knowledge and experience to help you gain a better understanding of constipation and its management. And after listening to his this lucrative profile, I am sure our audience is impatient to hear our speaker, Dr. Saurabh Patale, sir. So I would invite Dr. Saurabh Patale, sir, to begin with today's webinar, today's session. Over to you, sir.
Hello. Yeah, am I audible?
Yes, sir.
Okay, thank you, Dr. Pallavi, for such a nice introduction about myself. And I am really glad and grateful to IVPG and Dr. Bhagya sir and all of the organizing committee for giving me this opportunity to share my knowledge regarding the topic of constipation. Constipation seems to be a very dry topic. So many of our patients suffer from constipation. They go to medical practitioners and get all kind of laxatives. Most of them do get relief of constipation, but can get any relief from constipation because they are not properly worked up and classified so as which type of constipation they have. So I have made a PowerPoint presentation. I have tried to keep it short, and I'm sharing it on the screen.
Sir, your voice is breaking. Please make sure that your connection is proper or
Yeah. Yes, sir. Just a minute, I'm sharing the screen. Okay, is my screen visible?
yes, sir. Yes, it's visible.
Okay. So without further ado, I would start the presentation. About constipation, is it that hard? So we all know that our day goes, our day from afternoon to evening to night. It depends a lot on how the bowel movement has been in the mind. If it was bad, your days really tends to be a shitty one. And if you have good bowel movement in the morning, the whole day goes happy and gay. We all know Angry Young Mr. Amitabh Bachchan of Bollywood. In 2016, with the movie Piku, he actually tried to showcase what all goes on in the mind of a patient who has severe constipation. And his whole life revolves around the good, satisfactory bowel movements. And if we have a good bowel movement, that gives us a happy life. So constipation, as we know, it can be divided into chronic, which is going on for more than 3 months, and acute, which is
Sir,
generally
may I disturb you? May I disturb?
Sure.
Instead of putting the earbuds, if you can join with the using audio of the
Sure, sir.
laptop, it will be better
Sure,
because
sir,
the
I will do that.
voice is breaking.
Sure, sir. Doing it right away, yeah.
I've disconnected the buds. Am I audible now?
Yes, it's
Yes,
very
sir.
loud and clear now. It's very better.
Oh, that's great. That's great. Okay, thank you.
So
So as we
screen
know,
not
constipation.
visible, sir. So sorry to interrupt, but I think for many participants, the screen is not visible, sir.
Not visible?
No, sir.
Okay. Wait, I'll try to share it again.
Sir, open your presentation and reduce it, then go to the screen share option, then click on it, and it will show that window of presentation. Then click on it and share.
Yes. Okay, I think now it is visible, is it?
Yes, sir. Yes, sir. Now it is visible, sir. Yes.
Yeah, okay, sorry, the application had some issues. Okay, so I'll start from the beginning. It will take a minute. We all know that how our day goes every day. It depends on how we pass our stool in the morning. How is the first bowel movement? If it is bad, then we have a really shitty day. If it is good, the all day is happy and gay. We all know angry young man, Mr. Amitabh Bachchan from Bollywood. He also tried to tell us the same thing in 2016 by his movie Piku, where he showcased that how the whole life of a person with constipation revolves around a good bowel movement. What difficulty he faces in everything, in his emotional, his psychosocial behavior also. So all in all, if we have a good bowel movement in the morning, that gives us a really happy start of the day, and the all day goes well. So as we know, constipation can be divided into chronic and acute. Chronic, if it is going more than 3 months. Acute is generally short-lived. It is because of some recent changes in diet, travel, some stress, or departure from routine daily activities like shift working, and it resolves spontaneously by itself or on some fiber supplements or dietary changes or laxatives. Chronic constipation is the one which is nasty and which we commonly deal with. It can be divided into primary and secondary. Primary is also called as functional. Secondary means it has a certain cause, like some anatomical problem because of some surgery, if there are some adhesions, some anorectal diseases, colonic diseases because of some long-term drugs or dietary changes. But what we commonly face, the type of constipation is primary or functional constipation, where there are intrinsic problems of colonic or anorectal function. So by definition, if we go, primary constipation is a symptom-based disorder that results from dysfunction of colonic regulation of stool movement associated with incoordination of the anorectal neuromuscular apparatus and dysfunction of the bidirectional brain-gut axis. So here they have highlighted 3 points. First of all, it is a dysfunction of how the colon regulates the stool, number one. Second, there is a lot of coordination of our pelvic floor muscles, some relaxation, some contractions that give us a good bowel movement. So coordination of that, and somehow it is controlled from the brain by the help of brain gut axis. So these 3 things, if there is any problem in any one of these or multiple combinations of the factors, the person has primary constipation. It was defined by FGID diagnostic criteria right from 1978, but in 2016, Rome 4 criteria has given a proper definition of functional constipation. So the patient must have at least 1/4, that is 25% of the defecations. He will have 2 or more of these problems. There may be straining, there may be lumpy or hard stools. There will be a sensation of incomplete evacuation. This is a very common symptom which the patient gives. Sensation of anorectal obstruction. The patient sometimes require fingering or manual maneuvers to facilitate defecation. So if these criteria are fulfilled for at least 3 months and the symptom onset was at least 6 months prior to the diagnosis, it is classified as functional constipation. Most of the patients who are complaining of constipation more than 3 months, they fall under the functional constipation criteria. So we do not need to see this definition all the time, but most of them after 3 months of history, they satisfy this criteria of functional constipation. Indians are different. Our body, our genetics are very different. So as compared to the Western population, because all the data we know is from Western books, from Harrison, from other medicine and gastroenterology books, but Indian population is different because it already passes 1-2 stools per day because we have faster gut transit. Our intestines move fast, so 1-2 stool per day is normal for us. There is high dietary fiber associated with vegetarian diet. Most of us are vegetarian in Indian population. And we almost 60 to more than 60% of people have lactose malabsorption. So that also forms a confounding factor in passage of stools. So, and in Indian, the stool forms and patient's perception is more important than stool frequency. So if we go by definition, not all of them will satisfy the criteria. The feeling of incomplete evacuation is the main problem Indian patients have. कि motion करके आया मैं लेकिन ऐसा लग नहीं रहा है कि पूरा हुआ है. So I have to go again and again. So you will feel that the patient is going to the stool for 6 times. So it is diarrhea. No, it is actually constipation because he is not getting relief for the first time. So we have to really listen to the patient what he's talking. This Indian study also corroborates the same findings which I told just now, that subjective feeling varies widely among population. And you look at the fourth point, the feeling of incomplete evacuation was universal and was referred to as constipation by patients. So we have to understand that this feeling is pointing towards constipation rather than the actual stool amount of number of stools per day. There is Bristol stool chart which is available very readily on the internet. This can help us help the patient to tell the doctor how the stools are from type 1 to type 7. So type 3 and above are actually constipation. Type 5 to 7 are towards the diarrhea. So now when we have focused on primary idiopathic constipation, which is the most common type of constipation in population, it is again of 3 types. So this is the last classification. So no need of confusion. Primary and secondary. Secondary was because of some causes. Primary constipation is 60% most common, and it has these 3 types. Normal transit constipation means the colonic movement is normal. Slow transit constipation means the colonic movement is actually slow. And defecation disorders means there is some problem with the neuromuscular pelvic floor muscles, so that the anal relaxation is not there or the rectal compression is not there. Okay, so these are the 3 most common types. Out of which also normal transit constipation is the most common. Why this classification is important? Because how you will treat the patient will actually depend on what type of constipation he has. If he has normal transit constipation, the patient will get help with bulking agents. If there is slow transit constipation, then some drug which will increase the colonic movement. And if it is defecation disorder, then some behavioral therapies are required. So that's why this classification is important. As we can see here, normal transit constipation more than 60%. So the most common type of constipation finally is normal transit constipation. It is the most common type. They subjectively feel constipated despite normal motility throughout the colon. And the main symptoms are difficulty with evacuation. There may be some bloating, sometimes abdominal pain or discomfort, and hard. Sorry. Then comes the defecation disorder. Here the problem is with the pelvic floor muscles. There is pelvic floor dyssynergia, and there may be impaired rectal contraction, paradoxical anal contraction. That is when the anal relaxation should be there. Actually, it contracts, or there may be inadequate anal relaxation. The causes may be dyssynergia because the muscles of pelvic floor, they do not work in combination. There may be impaired rectal sensation. When do we get the urge to pass stools? When the rectum fills up. Rectum has pressure and mechanoceptors. They get excited when the stool gets collected there, and you get a supply an input to the brain that now I have to pass stools. So if there is impaired rectal sensation, that will be the defecation disorder. Or there may be some structural abnormalities in females, rectal or vaginal prolapse, rectocele, or there may be excessive perineal descent. These will be seen on rectal examination, digital rectal examination, and some radiological studies. So the primary idiopathic constipation, there is an overlap of many other things: disordered motility, pelvic floor disorders, which we talked about, and there may be some functional abdominal pain, which is not correlated to this thing. So the components of chronic constipation may overlap. So we have to give importance to all the aspects. Now comes the real thing: how to evaluate a patient who has come to you with constipation. So now you have taken the history, you have seen what the patient has, and now how will you evaluate the patient? First of all, as we all know, the hardcore thing of medicine is history taking. So listen to the patient very carefully and patiently. What are the constipation symptoms? He may give any of these: bloating, discomfort, hard stools, infrequent urge, straining, feeling of incomplete evacuation, need for manual rectal or vaginal manipulation, abdominal pain, fecal incontinence. I would like to point a thing about spurious diarrhea. There is a term called as spurious diarrhea. Actually, the patient has fecolitis. He has very hard stools collected in the rectum and sigmoid. And only the liquid stools, it trickles besides those hard stool pieces and comes out as liquid stools. This is called as spurious diarrhea, where the patient is actually constipated, but he is having fecal incontinence. So fecal incontinence may be a symptom of actually constipation and not diarrhea, where if you do a digital rectal examination, you will actually feel that fecolitis are there lodged in the rectum. So also we also have to see the response to previous laxatives and what diet the patient is consuming. Patient's past medical history and beliefs about the cause of symptoms are also very important. Sometimes the patient will say कि यार मुझे लगता है ऐसे हो रहा है. we generally tend to ignore this thing. Sorry, inko kya lagta hai? No, we should listen. It may be simply because the patient has moved from a Indian style toilet to a Western style that he's facing the constipation. So we should patiently listen to the patient's history. Also, we should consider secondary causes. Is there any history of abdominal surgery, so that there may be some problem with the rectocele, or there may be some bowel adhesions? Drugs, very important. Antidepressants, many of the patients are on antidepressants, calcium channel blockers and as antihypertensive agents, some anticholinergics, antipsychotics, even aluminum and calcium based antacids which are over the counter available, and iron supplements, they can also cause constipation. So drug history is important. Some systemic causes such as scleroderma, amyloidosis, hypothyroidism, neurological causes in bedridden patients, Parkinsonism, multiple sclerosis, Hirschsprung's disease, cerebrovascular disease, some metabolic causes such as hyperparathyroidism, diabetes, uremia, Addison's disease, some lifestyle factors such as inadequate fiber or fluid or physical inactivity, psychological causes such as depression or some eating disorders like bulimia nervosa or anorexia nervosa, or actually some GI causes such as colorectal cancer, colorectal ischemia, volvulus, megacolon, or diverticular disease, anorectal prolapse, rectocele. So all of these can be secondary causes. So we have to take all these consideration in the history when we are evaluating the patient with constipation. What are the alarm symptoms? When should we get worried that the patient is having constipation for 3 months? And what are the signs to worry? First of all, age more than 50. Because we are not that economically and socioeconomically developed, we do not have screening programs of colonoscopy like the Western population. So any person who is aged more than 50 with constipation is a red flag sign. That means the patient may have a problem, the patient may have even a colonic malignancy. So advanced age, presence of anemia because there may be blood loss, presence of actual blood in stool, overt bleeding in stool, unintentional weight loss of more than 10% of body weight, any family history of colorectal cancer or inflammatory bowel disease, any palpable abdominal or rectal mass, sudden change in the caliber of stool का size एकदम छोटा हो जाता है like a strip or ribbon, or change in bowel habits, and new onset of constipation as opposed to chronic constipation, and if there is significant abdominal pain. So if these are there, then the problem may not be a primary constipation. This is a secondary cause which needs evaluation, and the patient may have a more complicated disease than simple constipation, such as a cancer. So physical examination, the thumb rule, blood investigations, if required colonoscopy, and advanced physiological testing, which I will talk about shortly in brief. In physical examination, we should look for previous surgical scars, any abdominal distension and bowel sounds, any palpable mass, which can be fecalith or even a tumor. Gynecological examination to exclude cystoceles or vaginal or uterine prolapse, and digital rectal examination to check for anal tone, pelvic floor descent, to rule out any fissure, hemorrhoid, prolapse, and rectocele, or even a mass if it is palpable on the digital rectal examination. Blood investigation, very basic, hemogram to look for anemia, electrolytes to look for an electrolyte imbalance, thyroid function, cortisol to look for Addison's disease, and tumor markers in a specific set of patients more than 60 years of age with anemia and weight loss. Colonoscopy, it is generally normal in the most common type, that is functional constipation. But if there are any alarm symptoms or patients aged more than 50, it is important to rule out any colorectal carcinoma. As you can see in the lower images, the first image is of actually colorectal cancer. Second one is a stricture which may be because of some ischemia or injury. Third one is ischemic colitis because of devoid of the blood supply of colon. There are ischemic ulcers. And fourth, there may be stricture in the colon. So these things should be ruled out in high-risk patients by doing a colonoscopy. Advanced physiological testing, it is not routinely required, but it is recommended for those patients who are not responding to initial treatment and essentially have a normal colonoscopy. So in physiological testing, we are actually checking how the colon is functioning, how the movement, how the contractions are in the absence of an actual physical obstruction. There is no physical obstruction, colonoscopy is bang normal, but how the colon is functioning. So in physiological function, first of all comes the anorectal manometry. Anorectal manometry, there is a catheter just like a Foley's with a larger bulb, which can be filled with water. So it is inserted in the rectum in a deflated position. It is inflated with 50 cc of saline, and the patient is asked to defecate or give pressure. It has a lot of pressure sensors on the catheter. So it gives us a lot of information about internal anal sphincter function, external anal sphincter function, rectal sensation, recto-anal reflexes, how the rectal compliance is, rectal and anal pressure, how do they change during the defecation. So it gives us a lot of physiological information about the anorectal function. So it is very important, anorectal manometry. Then balloon expulsion test, it is basically done for rectal sensation. Similarly, there is a catheter with a 50 cc capacity balloon. That balloon is inflated, it is inserted into the rectum in a deflated position. It is inflated with 50 ml of water, and we ask the patient to pass stools. If a person cannot expel the balloon within 1 minute, it is considered to be failure of passing, that is dysynergia. That is, there is some problem with the anorectal neuromuscular apparatus that the patient is not able to pass the stool. So balloon expulsion test, BET, is a very simple test which is done in physiological testing. Then when we talked initially about normal transit and slow transit constipation, what we meant, how the colonic movement is. Colon kitna fast chal raha hai, kitna slow chal raha hai, kaun sa segment slow chal raha hai, kaun sa segment fast chal raha hai. So it can be done by use of capsules. So actually we take capsules, empty capsules, and we put radio-opaque markers in that. And then the patient is asked to swallow those capsules. And after some interval, serial X-rays are taken so as how the markers are moving in the colon. This is how it looks. So after doing this capsule study of colonic transit time, if there is slow transit constipation, so logically you can understand all the radio-opaque markers will be spread out in the colon. And if it is a defecatory disorder, that is some problem with the neuromuscular anorectal apparatus, all these will get gathered in the rectosigmoid region. So this simple colonic transit study will give us an idea if it is a normal transit constipation, slow transit constipation, or defecatory disorder. So this is how it is done. We generally use multiple capsules, the second type, and 1 capsule a day for 3 days, and abdominal X-rays day on day 4 and day 7. Our day 7 X-ray tells us a lot. If it is clear, that means there is normal transit constipation. If the markers are scattered throughout the colon, it is slow transit constipation. If they are gathered in the rectum, then it is the pelvic floor dyssynergia, PFD. It can also be done by scintigraphy, where radio-opaque markers are given in a meal, like technetium 99M, and they are scanned through a gamma camera CT scan, and it gives us the same information as colonic transit study capsule 1. Defecography is a new imaging technique. It is not actually available at many centers. It is done by the use of MR defecography. This is how, in a standing MRI machine, the patient sits, that box down, which is the patient is sitting on. It is actually a toilet bowl. The patient is asked to defecate in that bowl, and real-time MR imaging of the rectosigmoid region is done to see if there is any rectocele, vaginocele, if there is adequate rectal contraction and anal relaxation. So these are how the images look. In the MR defecography seen below, there is a rectorectal interception and prolapse of rectal mucosa outside the anal sphincter. Rectal descent can also be measured. Kitna rectum niche aa raha hai, which is abnormal if it is more than 3.5 centimeters on MR defecography. This I am showing just for your information purpose. It is practically not done everywhere. I think AIMS in Nagpur is doing it, and 1 or 2 MRI centers. But availability is an issue about MR defecography. Now comes the last stand, that is management. How to manage this patient? So it also has some specific steps. First of all, lifestyle measures, use of laxatives, biofeedback therapy, which is very important and very interesting, I will tell you, use of prokinetic or secretagogue drugs, and interventional treatments like even surgery. So lifestyle measures, very important. This diagram where it shows on the left side, where that orange colored person is sitting, he is sitting in a Western style, on a Western style toilet. You can see in the circled figure, the rectosigmoid angle there, it is held by a muscle. A sling is formed, and there is an acute angle there. So when the person is sitting on a Western style toilet, there is an acute bend over there, which hinders the passage of stool actually. Whereas the Indian toilet sitting style, which is considered to be the best actually, because of why we pull our legs up at the level of our buttocks, that angle, it gets resolved, and there is more straight anatomy of the rectosigmoid junction, which allows easy passage of stool. So squatting posture fully relaxes this muscle and forms a straight column in the rectosigmoid region. And normal sitting posture, it kinks the colon, it forms an acute angle. So use of such stool. The blue person sitting in the right side, when you can see, if you can see, there is a white colored stool. Actually, this stool is available in the market, in sanitary houses, in sanitary shops. If you can ask for a squatty potty stool, this is called a squatty potty stool. It can be used in people who are having problem with constipation. It can be used with a Western style commode, as you can see, and we can keep our feet on it. It gives a kind of squatting posture and helps with the passage of stool. So lifestyle measures very important. If somebody is having this problem, this tool comes very handy. Otherwise, exercise has a modest effect. Only one randomized control trial till date has been done, and it did not show any significant improvement in quality of life by lifestyle measures. Water intake also has a modest effect. No evidence of benefit if the patient is already well hydrated. In dehydration, yes, but a normally hydrated person, water intake is not actually much of an issue. But I agree that we also tend to tell the patient, pani jada piyo, pani jada piyo. But actually speaking, it is not really that helpful if the patient is already well hydrated. So laxatives are the mainstay. This is a very comprehensive slide. I'll spend 2 minutes on it. Sorry. As we can see, there are a lot of laxative which are available in the market. Bulking agents or fiber. Fiber is basically indigestible material which imbibes water, which absorbs water and swells up and gives a full colon. It gives weightage to the stool so that more and more mechanoceptors in the colon, they are stimulated and the person gets the urge to defecate. So it increases stool volumes, making it easier to pass. The isabgula or bran husk are the examples. It decreases the gut transit time and improves stool frequency. Stool softeners like sodium docusate and liquid paraffin, the cremafin syrup which we get over the counter, it softens the stool, making it easier to pass. It is less effective than the fiber to improve frequency. Osmotic laxatives are lactulose and polyethylene glycol, which is also very commonly used. It increases the fluid within the intestines, making the stool softer and easier to pass. It absorbs water from outside the gut. It calls water from the interstitial part. It decreases the transit time, reduces stool impaction, increases bowel frequency, and decreases straining. Stimulant laxatives, it improves the colonic contraction. So when we talked about slow transit constipation, in that stimulant laxatives are very important because you need to improve the gut, the colonic movement. So it improves the colonic contractions to move stools along the large intestine. Examples are bisacodyl and senna. They increase the frequency of bowel movements and decrease the straining. Dietary fibers, as I already told you, there are various ways of functioning, how they do by fermentation, by formation of short chain fatty acids that increase the colonic activity. They also stimulate, they also secrete the bile salts, which are helpful in stimulation and propulsion of secretion. And the edges of the dietary fibers, they excite the submucosal mechanoceptors and accelerate the colonic transit time. As we have seen that in defecatory disorder or slow transit or normal transit, everywhere fiber definitely has a role. So the best laxative actually becomes to be fiber if the patient is not taking enough fiber. Stool softeners and emollients like docusate sodium, it increases the fluid secretion in small and large bowel. Lubricants such as mineral oil are helpful, but in combination with stimulants. They just give lubrication. If the patient is having fissures or large hemorrhoids, in those patients, lubricants can be helpful. There is adverse effects such as malabsorption of fat-soluble vitamins. And if given in elderly patient, if the patient aspirates, there will be lipoid pneumonia, which is very hazardous for life. Osmotic agents, these are the next line, which is very good. They are actually poorly absorbed ions like magnesium hydroxide, magnesium citrate, sodium phosphate, and biphosphate, which are not really used now, but poorly absorbed sugars, that is lactulose or polyethylene glycol. These are the best osmotic agents which are being commonly used now. Lactulose is superior in terms of mean bowel movement frequency per week as compared to placebo and plain fiber. It is safe in pregnant or lactating women, children, and elderly. Adverse effect, it has some issue with flatulence, which is the primary side effect. Sometimes it may cause nausea and vomiting. Polyethylene glycol, it is very good in children and fecal disimpaction actually. If the person has fecolids, polyethylene glycol can be mixed in 1 liter of water and slowly given so that the fecal impaction is dissolved. Common side effect is diarrhea with liquid stools. Sometimes it may cause cramps, bloating, and flatulence. Milk of magnesia, which we see in the very commonly used syrup trimafin, it is the evidence for its efficacy is very limited. Adverse effects are also limited. There is always a risk of hypermagnesemia, especially in patients who are CKD. So CKD patients do not prescribe milk of magnesia. Stimulant agents such as bisacodyl and sodium picosulfate. These are used in slow transit constipation. They directly stimulate the small and large intestine peristalsis through colonic stimulation of the neuromuscular plexuses. It may cause discoloration of urine, melanosis coli, which is discoloration of the colon, abdominal cramping, and sometimes diarrhea. It is the one laxative which is habit forming. So when the patient asks कि मैं ये बहुत दिनों से ले रहा हूँ पर इसके बिना होती नहीं है, generally the patient is on either bisacodyl or sodium picosulfate. It is a habit forming drug. Inhibars and suppository, not very commonly used. Generally, if the patient is having difficulty in rectal evacuation, these drugs are to be given. Only weak evidence is there to support their use. Specifically, it is used in patients who have digestive dysfunction, impacted stool, ICU patients, the patients who are bedridden. In such patients, enemas and suppositories can be used. Phosphate, mineral oil, soap water, lactulose, many enemas available. Now, mineral oil and phosphate enemas are avoided because it is causing a lot of colitis. We have seen patient coming with perrectal bleed because of mineral oil enema or phosphate enema. Soap water enema, many of the times it is taken by people at home, but lactulose enema are really good. It can be taken self and they do not have any colonic damage history. As I told you, there may be serious damage to the rectal mucosa and can result from extravasation of enema solution into the submucosa. The most vulnerable site is anterior rectal mucosa. Phosphate enemas are not used, and soap enemas also can cause colitis. So lactulose enema is safe one which can be used. Now, very interesting topic, biofeedback, a topic very close to my heart. Biofeedback is actually potty training an adult. Simple words. Like we potty train a 2-year-old or 2.5-year-old kid, we actually do potty training for an adult who has this neuromuscular defecation disorder, that is pelvic floor dyssynergia. So by now, if you have done evaluation of constipation, colonoscopy is normal, colonic transit showed that all the markers are getting collected in the rectum. We have done an anorectal manometry and it has shown there is some problem in the pelvic floor neuromuscular synchrony. So now we have formed the diagnosis of pelvic floor dyssynergia. So biofeedback is actually a training technique which teaches the patient how to relax their pelvic floor muscles during defecation. It is used in PFD patients. So it works on the principle that when any behavior is reinforced, its likelihood of being repeated and perfected, it increases several fold. So what is done in biofeedback, like you can see in the left downside of the figure, there is a catheter with again a balloon at the tip. We insert this balloon deflated position into the rectum. We fill it with 50 cc of saline and we ask the patient to put pressure. कि आप motion pass करो. And how he is relaxing several of his pelvic muscles, how he is contracting several of his pelvic muscles, that is given in a diagrammatic form in front of him on a screen in simple things like red color and green color. If he is doing the right thing, if he is contracting right muscles, relaxing the right muscles, the green signal will come on the screen and we will urge the patient to do the same way. कि हाँ ऐसे ही करो, ये सही हो रहा है. If he is doing something wrong, somehow he is maintaining his anal tone very hard, he is not trying to contract the pelvic floor, red signal will come on the screen and we will tell the patient, no, you are not doing this right, try some other way, try some other way, try some other way. So 4-5 such cycles are required. Each cycle takes half an hour. Eventually in 4 to 5 cycles, the patient gets how the stool is to be passed properly. It is very funny, but it is very true. The patients with pelvic floor dyssynergia get benefited so much that when I was in Gurgaon, when I was in Delhi, I used to get patients from Assam who used to come to get biofeedback therapy done properly. So patients with pelvic floor dyssynergia, they will benefit tremendously with biofeedback treatment. Unfortunately, no laxatives work in these patients. They will just soften the stool. Patient को fecal incontinence होता है जब तक आप biofeedback therapy ना करो. So biofeedback therapy very important in patients with diagnosed pelvic floor dyssynergia. In various randomized controlled trials, it has been shown that it is 70 to 80% success rate for up to 1 year. It improves the constipation symptoms, overall symptoms, and dyssynergic pattern of defecation. But somehow there is lack of uniform treatment protocol. So although very few centers are doing across in India, it is done very properly in very, very few centers. And availability it is limited, as I told you. Not all cities are doing biofeedback. So to sum up the presentation, how to tailor the laxatives based on their symptoms and behavior and diagnosis. If the patient is having episodic hard stools, 2-3 दिन में एक बार मोशन होता है और जब भी मोशन होता है हार्ड होता है, first add a bulk fiber, isabgula husk. If it is not helping, you can add an osmotic laxative. If there is episodic reduced frequency, that stool is okay, stool is not that hard, but every day it is not coming, that means more towards slow transit constipation. So first laxative should be stimulant कि आप colon की movement बढ़ा दो. If it is not helping, you can add with osmotic or fiber. If slow transit constipation, osmotic followed by stimulant or in combination. If there is difficulty in evacuating like pelvic floor dyssynergia, biofeedback therapy is the first thing. If it is not helping, then stimulant suppositories are given just to stimulate the rectal part. Prokinetic agents, the new drugs which are available, such as prucalopride, Pruvis, Pruvik, Pruvel, what people are prescribing. The domperidone, levosulpride, mozapride, etopride, they all have activity only on upper GI tract. So don't believe that the patient is taking something like Pantocid DSR or Pantocid IT. So it will improve the bowel movement. No, it is only for the upper GI tract. Enterokinetic agents are tegaserod, which is not available. Cisapride, again, very limited availability. Prucalopride is the new drug, which is being used very commonly. It is a 5-HT4 receptor agonist. It improves the bowel transit, bowel function, GI symptoms, and quality of life. In elderlies, it is given at a dose of 1 mg per day. In adults less than 65 years of age, 2 mg per day is the dose, which can be given for 3 weeks. And after giving for 3 months, after giving for 3 months up to 2 years, the patient gets relieved with colonic movements. So better efficacy as compared to placebo. Secretagogues, these are also drugs which are available in limited availability though. Lubiprostone, it activates the chloride channels and increases secretion of water into the colon. So lubiprostone can be given at 24 microgram twice daily dose. It is well tolerated. A bit of nausea may be there, but not a very effective drug in my clinical practice that I've seen. Linaclotide, not available in India. Phase 3 trials are going on. Maybe next year it will be available. Again, albumin and methyl naltrexone, these are newer drugs which are not available. Just in studies they are going on. Tenapanor, eloxabibat, not available. Surgery is something which gives you to scratch your head कि constipation के लिए कौन surgery कराएगा. But no, if the person is having some rectal problems such as rectorectal interception, rectocele, vaginocele, in such cases rectal procedures will help with constipation. If there is slow transit constipation or complete atony of the colon that can be seen on CT scan or MRI difficography, that the colon is hugely distended, colon में कोई movement ही नहीं है. In such patients, sometimes it is difficult that the patient do not pass stools for 1 week, 10 days. Ultimately, उनको multiple enemas देने पड़ते हैं, polyethylene glycol पिलाना पड़ता है, then they pass stools. So in such severe cases of constipation, where there is complete irresponsive colon, in those patients, even colectomy is advocated. However, the patient should be selected very carefully because surgery is a big thing that you are going for in a patient with a simple disorder such as constipation. So at least 5 criteria should be met prior to consider surgery in a patient with constipation. First, the patient should have chronic, severe, disabling symptoms from constipation, that is unresponsive to medical therapy. He has slow transit constipation, as I told just now, or sorry. Or the patient does not have any intestinal pseudo obstruction such as ileus. The patient does not have any pelvic floor dysfunction based on anorectal manometry, and the patient does not have other symptoms such as abdominal pain, GI bleeding, or weight loss as a prominent symptom. In such patients, surgery may be considered. So first of all, when you come across such patient, dietary and lifestyle review should be done. Pharmacological agents such as osmotic laxative, stimulant, or enterokinetic drugs can be used either single or in combination. If the patient is not responding within 1 month or so, then we should review the patient, check for any alarm symptoms, reconsider your diagnosis, and sometimes their time more than 2 weeks may be required to assess the response. If the patient is not resolved within 1 month or so, then we should consider colonoscopy, psychological evaluation, or refer the patient to tertiary center for further physiological in the form of anorectal manometry and colonic transit studies, and if required, difficography. And then the patient may get benefited with behavioral therapy or biofeedback therapy. So to summarize, careful history taking and clinical examination, digital rectal examination is the thumb rule. Exclude other pathologies and secondary causes. Begin the treatment with dietary and lifestyle changes. Move to osmotic laxatives, stool softeners, and bulk forming agents. Resort to stimulant laxatives, suppositories, or enemas if unsuccessful. Physiological testing and biofeedback will be the next step if the patient is not getting benefited with the routine treatment. and surgery should be a last resort or to treat identified disorders that actually require surgical correction, such as rectocele or vaginocele. Thank you.
Thank you so much, sir. Thank you
Thank
so
you.
much, sir. I think it was a very nice presentation, right from the etiology of the constipation to its clinical presentation to investigations and the line of treatment. To again summarize the whole of this presentation in short, I would now like to invite our today's chairperson, Dr. Subhash Wage, sir, to briefly mention the essence of this presentation. Subhash Wage, sir, please, sir.
Thank you very much, sir, for giving us a wonderful insight to constipation with regard to its multidimensional diagnostic approach and the multidimensional therapeutic approach. In fact, when I heard the sir somewhere some 7 to 8 months ago, when Lions Club of Nagpur Ayurved, they arranged a teachers felicitation program at Arihant Hospital. That time I heard the sir on this beautiful topic, and when I heard it, it was so mesmerizing. Then and that time only I thought that sometimes we will call the sir on our platform, and I will make everyone intelligent in this regard by dealing with the constipation, which is very common complaint and which looks very
Yes.
simple.
Yes, sir.
Yeah, and we are using the drugs rampantly. We use stimulants, we use prokinetic agents, and whatnot. Even milk of action. These are all the commonest prescriptions we give. But as sir had highlighted, as when to prescribe these agents, particularly in general practice, we do not go for investigations for constipation.
Yes, true, sir.
We miss it. But particularly when the patient is elderly, above 60, and if the patient had a history of weight loss, we need to focus. We need to rule out the causes for colonic malignancy. That is very true. And particularly, and when we all of us, when we deal with the functional problem, while dealing with the patient also, we there is highly likely that we may also suffer from the constipation while dealing with such patients, because patient visits often and often, and they it puts you under stress, and even after giving so much therapy, he doesn't respond, and responds to the sedatives and antidepressants rather than the stimulants or prokinetic agents. So addressing the root cause of the problem and then instituting the therapy is what the message deliver perfect is for in today's lecture. I think all in all, it was a very wonderful talk. So I express my gratitude and thanks to dearest Saurabh Patale, sir. And as he was stuck up in the railway,
I'm really sorry.
he is
Probably,
actually the visiting consultant at Gondia. Every Saturday visits there, and I was in constant touch. We both were anxious. We started a meeting, and sir was the train stopped on the outskirts, and he was helpless. We were helpless, but putting our rest to all the anxieties and worries, and these. He joined as soon as we started. He assured that you start the meeting, I will join, and there how the entire thing is materialized, and everything uh, with little hiccups, but it ended uh, on very nice note. So thank you very much, sir. And ours is the organization which conducts this type of educational activities frequently. And our calendar is fixed yearly. We publish a yearly calendar of our activities, and hopefully we expect we will call you, and we expect rather your cooperation in this regard
absolutely delightful,
with
sir. I will always be there.
in future also on some other interesting topics related to GI
Sure, sir.
disorders. We may call you, and hopefully will respond to our plea. With this remark, I put end to my words, and again extend my sincere thanks to you, sir. Thank you very much.
Thank you, sir. Thanks a lot for the opportunity. And I'm really sorry for the delay And take home message for me today is you can do something for the block stools, but you cannot do anything about the block trains. So can't help that situation. Thank you. Thanks a lot for the opportunity. It was glad being here, and I would be obliged if I get such more opportunities to talk about various topics on GI. Thank you,
I
sir.
think we have consumed a lot of time of sir. If can we have few questions, one, two, three, one or two questions?
Absolutely. Absolutely. Yeah, I would love to answer. Thank you.
Dr. Pallavi, could you please read the questions in chat box and place to sir?
Sir, I'm not able to visualize any questions, sir. I will
Uh,
request all the participants, if they have any questions, they may put forward.
If
I don't.
required, Pallavi ma'am, you can share my number also. If anyone has any difficulty managing a patient, they can directly get in contact with me, and I'll definitely help out in
Sure,
whatever way
sure, sir.
possible.
Sure, sir.
Okay, ma'am.
As of now, as I cannot see any messages in the chat box or questions, till then we can continue with the further proceedings. And I would request Dr. Sita Biradar ma'am to deliver today's vote of thanks.
Yes.
In between, if we get any questions, then we can address those.
Yeah.
Good afternoon to all members of RVPGA family. I, Dr. Sita Biradar, Professor and Head BLD AVS Ayurved Mahavidyalaya, Vijaypur, Karnataka. Today I am having a great privilege to render vote of thanks. Thanksgiving is a time of togetherness and gratitude. I wholeheartedly thank our chairperson, Dr. Subhash Waghesar, for always being backbone and inspiration to our RVPGA family. Thank you, sir, for organizing such webinars. I wholeheartedly extend my sincere thanks for today's speaker, Dr. Saurabh Patale, sir, for his wonderful and informative lecture. I extend my to Dr. Pallavi Chowgle, Madam, Coordinator, RVPJ family, for organizing for making this webinar successful, and also all the members of RVPJ family for supporting and always making us very active, and also for smooth functioning of these activities, and also the organization.
One before finishing, I think one question that
for giving me the opportunity. Thank you.
many thanks, Sita Biradar madam. I
Thank you,
think
sir.
this is from everyone's part. Something about gut-brain axis and
Yes.
selective serotonin reuptake inhibitors. Sir, could you
Yes.
please throw some light on it?
Yes, so gut-brain axis is a very vast topic, and it is a new thinking in the field of neurogastroenterology. Now we are assuming, we are getting a lot of proofs that our apart from our central and peripheral nervous system, there is something called as enteric nervous system. Involuntarily, how our gut controls the digested food and the stools is being controlled by our brain by this manner. Most important two functions are bowel movement and bowel secretions. These are the two things which are controlled by the brain involuntarily through this enteric nervous system, and a lot of its manipulation is being done by the probiotics, or what kind of bacteria do we have in our bowel, what is our bowel genomics, what kind of bacteria, what kind of probiotic bacteria we have in our intestine, that manipulates this gut brain axis and manipulates the function of the GI system in the form of GI sorry GI secretions and colonic motility. So gut brain axis is actually the neurological communication between the gut and the brain, and it allows the functioning of proper bowel movement and secretion. So as to when we talk about selective serotonin reuptake inhibitors, they cause a lot of problem with this gut-brain axis mechanism. So they can be used as a drug in IBS-C actually to desensitize the nervous pathways. They are used as drugs in IBS. The patients who have functional bowel disorders, they are being given therapy in the form of SSRI. But SSRI can cause constipation. It can cause destabilization of this enteric nervous pathways and cause problem with the proper mechanical movement of the colon and cause constipation. I just now saw a question about what foods cause constipation. So we all know it is very logical. Maida jo hai, maida is refined flour. Refined flour means it is refined. It does not have the covering. It does not have fiber at all. So maida, as you see, जब हम मैदा भिगाते, it is very tenacious. Okay, बहुत चिकट सा होता है और it is not properly this thing absorbed by the gut. So ये मैदा जो है, it tends to cause constipation. It gets stuck in the bowel. It interferes with the mechanical movement of the colon. So maida is one drug which causes constipation very importantly. And more than what food you are eating, what you are not eating is causing constipation. For example, in Western diet, a lot of weightage is given on non-vegetarian food. They just simply eat beef, pork के जो slices है वो खाते हैं वो लोग, साथ में एक bread खाएंगे जो भी again मैदे की बनी रहेगी. So it is very devoid of dietary fiber. So maida is one drug which causes constipation, but lack of fiber is the more important factor that causes constipation. So people who are more on non-vegetarian diet, if they take a good amount of salad or other fibers in the form of roti or suji or stuff, then they may not have constipation even by consumption of non-vegetarian food.
And the entire list of constipating food stuff is given in Ayurveda also. For example,
Yes.
the chana, matar, etc. All those, the entire list is given. The second common the common problem, why I asked, because of this gut-brain axis, because in Ayurveda, in some of the mental disorders also, they have asked to clean the bowel.
Yes.
I used, when we used to read, why I just used to wonder why they have asked to keep the bowels clean by the purgation or whatever the methodologies they employed, and what the role they it has keeping the bowel clean, and it has an impact on mental disorders also. That
Yes,
is one
yes.
aspect. Second point of concern is rampant use of antibiotics, what is going on nowadays, and it
Yes.
kills many good colonic bacteria, and that
True.
lands the individual in depression. And the antidepressant that sometimes relieves the constipation.
So actually, our bacterial flora, which is the inhabitant of our small and large bowel, it tells a lot. It is like a genomic fingerprint of a person. Every person has different microbiotics in the small and large bowel. So there is a lot of going on. If we use rampant use of antibiotics, the helpful bacteria, they are washed away. The pathogenic bacteria takes up. It produces so many toxins which interfere with the gut-brain axis and cause such symptoms. So that's why the bowel purgation is also being prescribed as one of the measures in this problem. All the
Yeah.
pathogenic bacteria are washed off, and time is given for the colon and the small bowel to perpetuate the helpful gut bacteria and flora, so that they will have the proper amounts of chemical this thing neurotransmitters there, which will help the gut brain axis.
There is one disorder in Ayurveda called Grani, which coincides with the modern description of irritable bowel syndrome.
Mhm.
And in context to that, particularly the Bhayaj and Shokaj Atisar, which is because of the stress, mental stress, because of the anxiety related diarrhea. And the sometimes there is a diarrhea, sometimes there is a constipation. Means sometimes it is constipation predominant, sometimes it is diarrhea predominant, or alternatively it could be constipation and diarrhea also.
Yes,
Uh,
sir.
Muhur Baddam, Muhur Dravam, that term which they have used. I mean, Baddam is the impacted one, and Dravam is the liquid form one. And in that connection, they have also used this terminology, the bhayaj and shokaj, and means fearful factors. And the one, if one suffers from depression or grief or loss of, because of loss of dear ones, they have clear-cutly given the examples also. And in this disorder, they have asked to, for bhayaj and shokaj, means this type of grani, they have asked to the harshan chikitsa or ashwasan chikitsa, which coincides with the reassurance.
Yes,
Give
reassurance
the confidence
psychotherapy.
to
Yeah.
reassurance and give the confidence to the patient. And not only that, one more thing, they have asked to give frequent buttermilk
Mhm.
to buttermilk, which has the probiotics and
Yes,
yeah,
that's what I was coming to. Probiotics,
yeah,
Lactobacillus,
maintain the
Enterobacter
colonic
species.
physiology properly. So that was the
Right.
thing which I'm highlighting it, because our ancient ancestors, ancient physicians also use these various types of strategies to deal with the such type of syndromes and things.
Right, sir.
Thank you very much, sir. We have taken your lot of time, and
No
thank you
issues,
very
sir.
much again for spending your valuable time with us. Thank you, one and all. We will close the meeting.